I'll just do a quick introduction if you don't mind, and then we can let you get started.
Thank you.
Dr. Finelli is a urologic oncologist and surgeon investigator at the University Health Network, UHN. Some of you might recognize that more as Princess Margaret Hospital and affiliates. He is a professor in the Department of Surgery at the University of Toronto and is the head of urology GU site lead at the Princess Margaret Cancer Centre. And he was also the inaugural GU oncology lead for the province of Ontario. So Dr. Finelli, we're so excited you're here to join us today. It's nice to have Princess Margaret and UHN back with us, and we'll let you take it away. Thank you.
And I'm going to share my slides. Thanks for the kind introduction. Can everyone see my slides?
Yes, we can.
Great. So I wanted to go over this concept of active surveillance. And I think for patients, it's always a challenge because all we tend to hear about is the war on cancer. And unfortunately, many of our patients have advanced disease or high-risk disease. And indeed, it's a battle to survive and hope for cure. But like many tumors, even in the kidney cancer world, we kind of have two ends to the spectrum. And there are a number of individuals who are diagnosed with very small tumors. And then the dilemma becomes, how do we best manage them? So what I want to do is spend some time going over what we know about the natural history, and then touch on treatment, surveillance, and what we're trying to do to actually not overtreat, which seems to go against what we want to do for people in terms of doing our most for them. So as regards this presentation, I don't have any disclosures or conflicts of interest. There may be some slides that are really data heavy, but I'll try to highlight the key points for you. And for this slide, what we're trying to show here is that over time, we've seen an increase in the number of diagnoses for kidney tumors. And in general, many of those tumors are on the smaller side, and that's because of our access to imaging. And if you look at survival or mortality, you see it's gone down. And that may not necessarily represent how well we've done for those with advanced disease, but that we've treated many with more indolent disease. One of the feeders or causes for what we're seeing is our improved imaging. For those of you that are older like myself, you'll know that you used to see a doctor and the mainstay was a history and a physical exam, and not necessarily a referral to get an ultrasound just because that's part of your annual. And only over time now do we see these new imaging modalities become available. And most patients now undergo imaging, even if they don't really have symptoms or signs. And what that does is it leads to incidental diagnoses, or meaning a diagnosis in the absence of symptoms. And what's evolved then is a kind of find it, fix it paradigm. We image people, we find things, we fix them. And I think the motivation was genuinely to help people, and that we wanted to find and repair or remove so that there wasn't consequences down the road. And if you look at this timeline, actually, Charles Robson was the professor and chairman at the Toronto General Hospital and University of Toronto, and he actually described radical nephrectomy, which was the complete removal of kidneys. But you have to understand, when he practiced, that was in an era when we didn't even have CAT scan or ultrasound. So they were really bad tumors only that they were finding on tomograms or those with symptoms. And then as we went through time, we started saying maybe we don't have to take out the entire kidney, and maybe we can get away with just removing the tumor-bearing part. And then trying to diminish morbidity. Let's do it through smaller holes with minimally invasive surgery, or maybe just stick a needle in and burn it or freeze it. And then more new technology like robotics, and many of these are very expensive, but help us do things better. The question is, how much better for how much money? And ultimately, maybe we should ask ourselves, does every patient with a small renal mass need treatment? This slide shows that if, again, increasing incidence, meaning new diagnoses, and look at no change in mortality. So that's disturbing. We're finding more and more of these, and maybe we're treating them earlier, but we haven't really moved the dial on how many of our patients have died from this disease. What's also interesting is depending on where you reside and your access to imaging, you're more likely to have your entire kidney removed. So if you live in an area where there's more imaging, you'll have surgery more likely as a treatment. This problem isn't unique to kidney, and actually the stronger stories have already been laid out in prostate, thyroid, and breast. 3 sites, again, where some patients will have unfortunately significant diagnoses, but a number of patients will develop tumors that are quite manageable or maybe don't need management at all. And we're starting to see this philosophy now go across different sites where, again, maybe we're over-treating in some instances. Dr. Kapoor alluded to this when he talked about the cure rates. And if you look at here, T1A are tumors less than 4 centimeters. And when you have a tumor less than 4 centimeters, if you undergo treatment, you have a greater than 95% chance of being cured. And that is obviously what we strive for. But I don't think the surgeon could take all the credit for this. Perhaps it also reflects the biology of this tumor and that it's not as lethal or malignant as we would think. For the most part, there are emerging technologies. We heard some promising commentary regarding radiation, which historically didn't have a role. Ablation is an alternative, but for the most part, surgery remains the standard of care for localized kidney cancer. Whenever possible, particularly for tumors less than 4 centimeters, we want to remove the tumor and preserve the kidney so that we don't lose renal function over time. If we can, we try to do this through smaller incisions, minimally invasive, such that the recovery and maybe the quality of life detriment that can occur with intervention is less. In the bottom right corner, this is a partial nephrectomy, and you can see how much kidney we're able to save when we only excise small tumors. Often, conventional or open surgery, which still remains very common in many jurisdictions, particularly in Canada, is an incision over your 11th rib. And no matter how tough you are, this can be a very difficult incision in terms of recovery and chronic or long-term wound-related morbidity, pain, altered sensation, flank bulge, etc. When we can, we'd like to make smaller incisions, use cameras and instruments deployed within the abdomen to complete the surgery so that the recovery is much easier on our patients. An alternative to surgery is something called ablation, and that can either be performed with cooling or heating. So I generally speak to what's called percutaneous energy ablation, which means you poke the skin, insert a rod into the tumor, and either freeze or burn it to achieve complete cancer kill. The benefit of this approach is that it can be performed as an outpatient without any incisions or just a small one to accommodate the probe that's inserted. This is becoming more popular, and if you look at long-term results, in particular for tumors less than 3 centimeters, it is quite effective and preserves kidney function. This is a cartoon depicting what I was commenting on. Surgery is the standard of care, as I mentioned, and energy ablation is clearly an option. Both are effective. So then the question is, why not just operate or treat everyone? And I'll share some data with you as to why we pause in considering who or who doesn't need intervention. No matter how good our intentions are or how gifted the surgeon is, patients will experience complications, either short-term or long-term, from the intervention. I've only chosen 1 or 2 studies to highlight the types of numbers that we see even in experienced hands. With partial nephrectomy, you can see that the 30-day mortality rate was nearly 1%. This could reflect people who are medically unwell and maybe were high risk for surgery or potentially secondary to a complication. So that means 1 in 100 people who went in for this operation unfortunately didn't leave the hospital or died shortly thereafter. And this was not from their disease. Upwards of 5 to 10% of people will have a transfusion. Sepsis is a serious infection. You can have respiratory complications in 6%, acute injury to the kidney 6%, and thus it isn't without harm that our intervention is performed. I know this group of surgeons. I actually trained at the Cleveland Clinic, and they are very talented surgeons. So you're looking at an experienced high volume center, and I'm going to show you some complications from this place. This was breaking down the tumors by less than 2 centimeters or greater than 2 centimeters. What you can also notice from this series is that even though they wanted to remove kidney tumors, anywhere between 15 to 25% of what was removed was actually benign. So you could either see that as good news in that you're lucky you didn't have a cancer, or you could pause and say, maybe about 1 in 4 to 1 in 6 people didn't even need the operation. Looking again at some select complication, even in this very small tumor group, less than 2 centimeter, 14% experienced complications. This Clavian grade is a scoring system for the degree of complications, and 3 and above are very significant ones. Even in this series of very small tumors, almost 5% had a clavulin 3 or higher complication. Almost 5% transfusion rate, almost 1% reoperation or angioembolization rate because of bleeding. Getting back to the open surgery, this is the bulge I was talking about, which can be very frustrating to patients long term. Robotic surgery is wonderful, but it's not standard of care in Canada and only available in a handful of centers. So what is active surveillance? So the concept of active surveillance, which as a uro-oncologist, I spend more time treating prostate cancer this way than kidney, is one that involves very close monitoring with the intention to intervene when cure remains possible. This is very different than watchful waiting, which is when we have someone with a tumor who is so medically unfit or has other very significant conditions that we would never intervene. We would only try to manage symptoms if they developed as a consequence of the tumor. For example, someone with really bad airway disease or emphysema and they're on home oxygen. These are not surgical candidates, and they are also at high risk of passing away from these other conditions. The reason we don't do active surveillance for everyone is that small but real concern that if I don't treat the cancer, it might spread. And this is really the challenge to active surveillance. We haven't developed the most sophisticated means of knowing who's at risk for metastases. This graph shows you patients who are diagnosed. These are not patients on surveillance. This is a snapshot of, let's say, 100 people who were diagnosed with kidney tumors, and the percentage based, let's say 1,000 people, the percentage based on tumor size when they walk through the door on the risk of having metastases at diagnosis. So look at these large tumors. If you have a tumor 7 to 8 centimeters, there's about 1 in 4 patients who will show up actually with that tumor plus spread. And even in these small tumors, there's about a 1 in 25 chance that you will already have metastases with a small renal mass. What's more important to look at, though, is who develops metastases while on surveillance, and I'll come to that later. This is the only experience we have, and it's a pooled analysis of our centers who do surveillance or did so early. They looked at 880 patients. 18 of them developed metastases while they were being watched. This happened over a period of 5 months. The reason we want to avoid this is, as you heard in the earlier talks, we really don't have a great opportunity for cure once you have metastases. What's interesting from this series, though, is 1 in 4 of all the tumors, not those that spread, didn't even grow during this time period. When you look at the risk for spread, it was the larger tumors, those that were 4 centimeters, larger volumes and growing more quickly, almost a centimeter a year as opposed to 3 millimeters a year. So is every enhancing kidney tumor malignant? You'll show up, your doctor will image you, they'll refer you to a urologist, and no matter how sophisticated that urologist or radiologist thinks they are, I can tell you right now, they won't know for sure if it's malignant or benign without sampling the tissue. The only obviously benign tumor is a fat-containing tumor called an angiomyolipoma. This is a large series from the Mayo Clinic where they operate or used to operate on all small renal masses. And you can see here that once tumors are really small, let's say less than 2 centimeters, anywhere between 1/4 to 45% of the tumors removed were benign. And if you look at what's called grade in the cancer, which speaks to how deranged the cells are and the risk of spread, the vast majority of these small tumors are low-grade tumors, meaning they're unlikely to spread. This is a slide courtesy of one of my colleagues, Phil Fiorazzo, who oversees the Discern Registry at Johns Hopkins and is also interested in this space. He looked at the data from a systematic review, and in his opinion, he felt that roughly 80% of the masses less than 4 centimeters were indolent. And calculating that in the American health system means that there's approximately 5 to 10,000 very low or low-risk tumors that are removed annually in the United States. Some facts. Before the imaging era, more than 50% of kidney tumors were not detected until autopsy. That meant patients were dying from other causes, and at the time of their autopsy were found to also have a kidney tumor. Size and stage correlate or are associated with outcome. Tumors less than 3 centimeters rarely spread, and as I mentioned, 20 to 40% of tumors less than 3 centimeters are benign. So how fast do these grow? When we look at the experience from 9 institutions, the average growth rate is about 3 millimeters a year. If you look at these studies, you have to be careful because we often use the word progression when a tumor goes greater than 4 centimeters. And progression usually in the cancer world almost suggests spread or local invasion. But in the small renal mass world, progression usually means they've grown above 4 centimeters. And here is one of our first challenges in surveillance. How many years do we watch someone? Who do we choose to watch? If eventually they're going to be treated, why did we even watch them? And these are all very important questions that we're trying to answer today. This is our large multi-center Canadian study led by Mike Jewett and a number of other key people in Canada. You may recognize the names. And we contributed significantly to the world literature. As you can see here, the growth rates were very similar to what I showed earlier, but each of these lines represents a different tumor. And look at the enormous variability. Some tumors actually shrink over time, And I will show you a slide on tumors that actually disappear. And there's others that grow quite quickly. And obviously those would be more serious. What we also learned, because many centers don't biopsy, but some do, that whether they were benign or malignant, you couldn't tell based on growth rates. Some malignant ones grow slow, some benign ones grow fast. So growth rate alone is not perfect, but it does guide us, and we're cautioned when it grows quickly to intervene. These are the delayed intervention rates. And as you can see, at about 5 years, almost half of the individuals underwent treatment in the DISCERN study from Johns Hopkins and Philadelphia. This is an important piece of data to keep in mind because we counsel our patients on the likelihood of intervention. And again, 4 centimeters was the cutoff. When you look specifically, though, at the Hopkins series, albeit a bit of a self-fulfilling prophecy, but after about 4 years, the real favorable players have declared themselves, and those tumors don't grow much at all. So it's really in the first few years that you start figuring out who's going to last on surveillance and who isn't. We often image people quarterly or twice a year early on. So variability in growth rate is greatest in the first year, and this decreases over time. And the elevated growth rate happens early. So we got to be careful and image at short intervals and consider biopsy, which I'm going to come to next. For disappearing tumors, it's quite interesting to me. It's rare, but it does happen. And it makes you wonder about the host immune system or other factors that may be at play. As you can see here, some of these tumors vanished early and some vanished after 7 years of surveillance. At the current series, this is an older one, we still believe that active surveillance is underutilized, and only about 10 to 20% of eligible patients are being treated this way. This number is now closer to 30 to 40%. But kidney cancer is a very heterogeneous, is the word we use, disease, and hence why I'm a firm believer in biopsy. My whole motivation in the research I do and in the way I treat my patients is to try to individualize the care plan, individualize it based on the tumor biology, and later I'll come to how to individualize it based on the host. Each of these tumors is unique, and the only way to know which tumor the patient has, or to know as best you can, is with a biopsy. Because we biopsy, we also learned from our center with a recent publication that if you have a papillary type 1 tumor, your tumors actually grow about 1 millimeter a year on average, as opposed to 3 millimeters a year, which is what we see with clear cell tumors. This is how a biopsy is performed. It's an outpatient procedure with truly minimal risk. Kidney biopsy in the setting of kidney disease has a higher bleeding risk than biopsying a small kidney tumor. That's the gauge needle. This is often performed by radiology, some centers, urology. They use a dual sheath to try to protect from what's called tumor seeding. This is our experience over 13 years of more than 500 biopsies, and more recently I just looked at our data and we're approaching 1,000 biopsies at our center. 130 of the 500, so roughly 25% of the tumors were benign. These patients were managed conservatively. And as I showed you earlier, look at the growth rate of papillary type 1 versus clear cell. So wouldn't you want to know if you had a papillary type 1, even if the confidence was only, let's say, 90 or 95% that you have that? Let's not forget the host. And this is one area that requires much more research. And I know this is a patient forum, and it's very similar to when I speak to my patients in the office. No one likes to talk about their mortality. It's uncomfortable. But what we really try to do when we manage the tumor is also think about how well our patient is. How robust are they? How likely are they to become ill or pass away from another cause? Because only when you put those two pieces of information together will you be able to manage them in the most appropriate way. And we still have a long way to go. And the tumor, you might read about small kidney tumors, but look at this. Obviously, if you want to have one, this would be the one to have. Much more amenable to excision with minimal kidney damage. An unfortunate individual who gets one in the center of their kidney like this, there's bigger decisions to be made. So we have to also get better at how we annotate our tumors and how we play in location and risk of complications versus risk to the host medically and ultimately risk given the biology of the tumor. This is just CAT scans, again, showing the variability. One on the outside, one right in the middle where the main blood vessels are. Both are called small renal masses. Both, in this case, are quite different in the consequence to the patient or the implications to decision-making and treatment. So in conclusion, small renal masses have a favorable prognosis. The 10-year metastatic rate is closer to 1%, but ranges 1 to 5% in published series. Now we have histologically characterized groups of patients because we biopsied many of them before watching them, and we're learning more and more. Initial surveillance for tumors less than 1 centimeter, especially non-clear cell, and even up to 2 centimeters is very reasonable. I would also say as a surgeon, very, very small tumors sometimes are more difficult to remove or find than slightly larger ones. Ablation should be discussed for biopsy-proven renal cell, and now we know that radiation is also an option, particularly when the risk of anesthetic is greater or the patient has competing health risks. We do require prospective trials with meaningful and measurable endpoints, and this is a real challenge for us because most of the trials that are funded well are those that involve drugs because our partners are industry. And obviously, although they want the best for our patients, they're also in the business of kidney cancer. Many of these questions that we're looking to answer have to do with surveillance and intervention, and there isn't that same opportunity to partner with industry. So funding is a challenge. Lastly, I like to close with this slide because I'm very frustrated when I meet surgeons who immediately want to remove every small renal mass. And I firmly believe that we have to get away from this approach, and hopefully we'll have more personalized management of our patients. Thank you.
Thank you so much, Dr. Finelli. I really appreciate that very informative talk. As I said, this subject is a little bit near and dear to my heart because I am an active surveillance patient and actually have been an active surveillance patient for 10 years. So I am one of the very fortunate that my tumor is extremely slow growing and I have been able to thrive well, and I have received excellent care from my team. So I appreciate you enlightening us a little bit. Thank you also for clarifying active surveillance and watchful waiting. That was something I thought was interchangeable. So that's good information for us. It explains a little bit. And I'm truly interested in the disappearing tumors, as you can imagine. I hope someday I fall into that category. But some of the questions that we get from our patients regularly is anxiety. And that is a very fair question. The first few years when I was on active surveillance, it was always at the forefront. So maybe you can enlighten us. How do you help your patients cope with anxiety?
It's an excellent question. And we've had some studies published, one of the original ones from Serena Matan. And I think this again falls into us needing to be better in our assessment of what I call the host or the patient. We're all made up differently. There are patients who come into my office that are terrified of even thinking of an operation. And there are others that are terrified by the risk of spread and want to have surgery. So when you say anxiety, I see both sides or ends of this anxiety story. And it often plays significantly into the decision of treatment versus surveillance. Once they've opted for the surveillance, the anxiety piece, I think, can be managed. We're very fortunate to have a multidisciplinary team at our center, a very strong psychosocial group that emerged initially from our prostate cancer patient practice, but now moving into the kidney cancer patient practice as well. A big part of managing anxiety is very clear communication with realistic expectations, and ultimately reassurance with closer follow-up initially. At the end of the day, though, if a patient is living with such significant angst, I don't think any clinician would force them or strongly push them to surveillance. It's something that should be considered in the decision making of that patient. And so, although we can help you with anxiety, I also think some patients are beyond the interventions we can offer, and perhaps intervention is actually the best way to treat the anxiety and the tumor there.
I agree. And good. Thank you for sharing that. I think some of our patients sometimes say to us when we're in conversation that they're nervous that their doctors are just not paying attention to them, or they just don't want to treat them. And this is not the case. I can attest to that, but maybe you can just reassure them this is truly a viable treatment option, and doctors are not just pushing them aside because.
I would hope that no doctor is pushing them aside. I would also say to the patients in the audience that from a financial incentive side, we're more incentivized to actually operate than to observe. Even if you observe someone for several or many years, you will remunerate or make less money. So the motivation is actually really trying to help the patient. Having said that, what I'm concerned about, and it's something that we're looking in our prostate cancer surveillance studies, is what I call complacency. And I don't say this in a judgmental way, but we have to be careful that if someone's tumor is growing, we don't just think, oh, it just grew a little more, it just grew a little more. You have to sometimes really pause and take time and look at the images and maybe measure them yourself and look at the growth rate over time to make sure that you haven't just become comfortable and you say to the patient, yeah, it's growing a little bit, we'll see you back in 6 months. So I do believe that's an important piece to keep in mind as a patient in your communication with your doctor.
Okay, good, thank you. Mona, I think that you have a question. Maybe you could join us and share the questions that you have from the audience.
Yes, it was from Zahid, and I was hoping he was going to answer me because I did have a question because I'm not sure which part of the presentation he's referring to. So he's saying that this is all about kidney cancer tumors. Does this also apply to oncocytomas? Am I pronouncing that right?
That's yes.
I have surgery for an oncocytoma in January 2021, left kidney, and another one on the right after recovery of the first operation. This might seem familiar to you, Dr. Finelli, because he says you're going to do it.
So this is a very good question, and and something I think patients who have oncocytoma can appreciate. So oncocytoma is a benign tumor in that we don't believe it metastasizes. It doesn't spread. If you look at the tumor and go down a little deeper into the cell and into the kind of the DNA, there is a bit of a relationship and maybe a spectrum from oncocytoma to what's called a chromophobe tumor. We used to remove oncocytomas. We watch them now, but we're also respectful that we're early in this experience. We've published extensively from our group at Princess Margaret, and we've been doing this for almost 10 years or more. So we have to make sure that we don't expose risk because of our lack of knowledge that we haven't gotten to yet. The other controversy is kidney function. So we're always trying to balance how much work we do on our patients, because multiple surgeries in the absence of metastatic risk is only going to damage the kidneys. And it would be a shame to have someone land on dialysis because we operated so many times for tumors that we're not going to spread. So we're really at this point now where we don't have 100% confidence in some of these growing oncocytomas that may be growing quickly. Are they a mixed tumor? And we're trying to find our way. That's the most honest answer I can give you right now. We know it's benign. I think it's a little too deep of a conversation for this forum and this meeting, but it's a real hot area because the majority of the benign tumors are oncocytomas. And if we can really nail this, we're going to keep 25% of the people out of the operating room.
Good, thank you. Thank you. Do you have any other questions, Mona?
Oh, that was it.
I think you touched on RFA a little bit, and I think one of our patients has asked, why do they not necessarily hear about it as much? Is it not a forefront kind of treatment?
So I think the reasons you might not hear about RFA is there's only a handful of centers that offer RFA, is
Okay.
one. Second, we just recently saw a publication with more than 10 years of follow-up.
Oh.
So the confidence in treating with RFA, I think, has now reached a point where I know we do a significant amount of it.
Mm-hmm.
Although the option is very appealing,
Mm-hmm.
only a small percentage, I shouldn't say small, only a percentage of the tumors could be managed this way. The needle needs to go through the abdomen, and if the colon or the intestine, for example, is draped right over the tumor, radiology will not want to treat that tumor because you might have a thermal injury to your bowel. If the tumor is too close to a major blood vessel, you're going to have what's called a heat sink. So the temperature will never achieve the critical amount needed to kill the entire tumor. So that goes back to the drawing where I showed those 4 different tumors again and the host. And what I'm hoping, as we put together all the pieces of data and information, that we can maybe make a map where we have tumor location, patient features, and maybe this is better than that. We know anecdotally in our minds, but I would love to have data to support that so that there's more informed decision making. But I think those are the main reasons you're probably not hearing about RFA.
And good points and good reasons. Thank you. Go ahead, Mona.
Yeah, I had a whole bunch that came in now. Is there a big risk of kidney damage with a biopsy if the tumor is in the center of the kidney? And there's another part to what you're saying. I should add that I have bilateral disease, right kidney removed in 2012, now a tumor in my left kidney.
So the risk to the kidney in my mind is minimal. You will hear stories of someone who may have had some bleeding, but in no way does the risk even come close to the risk of intervention.
Mm-hmm.
In this particular patient situation, most people who have a tumor on one side will have a similar one on the other. Maybe 15% of patients will have discordance, a clear cell on one side and an oncocytoma on the other. So I would say to myself, what are the stakes? So is this a straightforward partial nephrectomy? Is it one that may result in complete loss of the kidney? And depending on the stakes, I may be more motivated to biopsy in this situation than not. And I think if the stakes are high, I would want to know what's being treated before they treat now in the setting of a solitary kidney.
A question from Ed. I had a partial nephrectomy 6 months ago for a 4.5 centimeter tumor. We are tracking another mass in my other kidney. Scans have showed it has grown 5 millimeters in 6 months, and it is now 1.2 centimeters. What is practical limit for biopsy? And he says also, is it common to have a partial nephrectomy on both kidneys?
in my practice, it's common to have a partial nephrectomy in both kidneys. I think in the world, it may not be that common. Yes, people do develop bilateral tumors with or without hereditary predisposition, but obviously hereditary syndromes are much more at risk for this scenario. A 1.2 centimeter kidney tumor can be biopsied. I think the location and the expertise or experience of the center will drive whether I would recommend it at this time. The fact that it grew 5 millimeters is faster than I'd like, but be very careful, because if it was an ultrasound, for example, and a CAT scan, I would want a CAT scan or an MRI to make sure that that measurement is accurate. We like to mix the modalities because of the cumulative radiation with multiple CT scans and with our ability to access imaging. So if that was a rapid growth, but it was on an ultrasound, I'd recommend a CT before anything else.
Mona, we'll have one more, okay, Mona? Please and thank you.
One more? Okay, I've got, all right. All right, I'll just take them in order, I guess. It's a question from Clive. My urologist is not in favor of biopsy due to a possibility of a false negative. Is this a concern?
So, you know, there probably isn't a national or international meeting that I don't get up there and I deal with this. And one of my favorite debates is to debate the merits of biopsy. We showed that biopsies are diagnostic 90% of the time. We don't like to use false negative. We like to use the word diagnostic because that speaks to, one, was adequate tissue obtained? Two, did the pathologist have the confidence to render a diagnosis? So false negative almost suggests we told you it's not a malignant tumor and then you had it. So that's why that statistic is one that I would avoid in this setting. So I would say it's 90% accurate, meaning what we get is what you have. And the reason I say that is because we've looked at our data when we've actually operated, and the term we use is concordance. If the biopsy showed X, did we remove X or did we remove Y? And this is really important data that we need to now disseminate. And we need to also disseminate skill for interventional radiologists, and we need to also help urologists become more confident in this. I get text messages from many colleagues who send me these reports with no diagnosis, and they say, you know, Finelli, you convinced us to get a biopsy, now look what I have. I don't have anything, and I'm back to square one. You know, patients may not want to hear this. I think our intentions are really good, but you have to understand that we also keep learning and keep improving. And so there is a continued medical education and training piece that exists in our culture, a learning curve that exists. And I just ask for your patience.
Good answer. Okay, well, we so appreciate, I apologize to the other questions, but we should let you go. And we truly appreciate you joining us today and all your shared information. It's been very informative, not only for me, but I bet for the community as well. Thank you so much, Dr. Finelli.
Thanks. Have a great evening. Bye-bye.
You as well. Bye-bye.